Yes, they do. Like, that's the whole point. All right, let me make sure I'm recording over here. Yes, I am. All right, I know. My basketball belly. I'm getting so hot in here. Ready? Hey, what's up, everyone? My name is Erin and Daneele, and welcome to Chosen. Today, I am so excited because I have a special guest who is actually an OBGYN at Brigham and Women's Hospital, and she's also an amazing faculty member at Harvard Medical School. Please welcome my awesome friend, Dr. Juliana Schantz-Dunn.
Thank you, Erin. I'm so excited to be here. It feels like a privilege to be on Chosen. I've watched your Chosen videos, and I'm really excited to talk with you today.
Thank you. Well, today I brought you on the channel because I really want to talk on this spectrum of losing a baby, whether it be by miscarriages, stillborn, infant loss, and then going into the whole, trying again. So the first question I want to ask you is, scientifically, medically, why does this happen? Like, for women who lose their babies, why?
I think that's a big question, and we don't know all of the answers. I think sometimes when this happens, and I should say that, for what people commonly refer to as miscarriage, we try to call early pregnancy loss. And early pregnancy loss is super common. It can happen in up to 40% of women of reproductive age who are trying to conceive, which I think is really surprising for a lot of women to find out that it's that common, because people don't talk about it a lot. So often when somebody's going through an early pregnancy loss, they're pretty isolated. But out of the early pregnancy loss, so this refers to pregnancies like in the first trimester, about 70% of them have to do with the genetics, like the chromosomes, how the pregnancy came together. It just didn't come perfectly, and so it couldn't continue. And then the other 30% is a sort of combination of other factors, whether it be like somebody has something anatomic in their uterus that prevented the pregnancy from growing because of a physical issue like a fibroid or a polyp or something that can grow inside the uterus. Some women have exposures to like toxins or stress, a couple of underlying medical conditions that can make you higher risk for pregnancy loss. But a lot of times we sort of presume it's genetic, but we don't have the answer, with 100% certainty.
How often do you see this happening?
Early pregnancy loss is the most common of those things that we see. I would say even within that, when we say like 40%, that comes from surveys of like thousands of women who've had babies who answer a survey. Did you ever have a miscarriage or like a chemical pregnancy or a loss? And even with that, there's, because pregnancy tests are so good, some women find out they're pregnant nowadays before they would even have missed a period. Whereas back when we didn't have access to really good pregnancy tests, there were probably women who were pregnant, but then their period just came like a week later, heavier. Mm-hmm. And so they didn't even know. So that's really common in that first, within the first 12 weeks. But the earlier in pregnancy, the more common. Okay. That as you get past 20 weeks, that's where we would refer to it as like an intrauterine fetal demise or a stillbirth. The rate of stillbirth in the United States, and that's pregnancy loss after 20 weeks of gestation, is about 6 per 1,000 births. In the US, that rate sadly has stayed steady over the last couple of years. Globally, the rate is much higher. It's like 35 per 1,000 live births, but that's because it includes a lot of places where there's not good access to medical care. And then beyond that, with like a neonatal death or like a newborn or an infant loss, that would be even more uncommon.
I want to talk about prevention. You hear a lot of things like you were exercising too much, you were reaching up high above your head. Is there any truth to that? Is there anything that we can do as women to prevent miscarriages and stillborns?
That is the first thing that I try to tell my patients, is that it wasn't your fault. If it were that easy to just jump a baby out or ride a bike too hard or lift a box and have a miscarriage, then, we wouldn't be having other debates that we have in this country. Like, it's not your fault. There's other things that went into it. Now, that being said, there are some things that can be done to improve your chances of maintaining a healthy pregnancy. So, for example, if you have diabetes, we know that women who have poorly controlled diabetes, or their diabetes is not under really good control, they're going to be at much higher risk of having a miscarriage, because the high glucose, the high sugar levels can be toxic to a new embryo. We've even found too that women have better outcomes if they can be closer to their ideal body weight when they're getting pregnant. But I wouldn't ever say that somebody's miscarriage happened because they were overweight or because they, did something they weren't supposed to do, with maybe the exception of you were taking a medication or taking a drug that was toxic to a developing embryo. So, most of the time women aren't doing that because they've been really cognizant of, not wanting to harm a pregnancy. So people should get rid of the guilt around pregnancy loss, because especially if I'm saying the majority of early pregnancy loss is genetic, you can't control that. When that egg releases, you don't know how it's coming together with the sperm. So
I have come across so many women who are hurt, they're broken, they're emotionally unstable, mentally, psychologically, they're impacted by the loss that they had. Maybe it's years ago, or maybe it was I don't know, a few months ago. How do you deal with that with your patients? What are the resources that are given, or is there some type of protocol in the hospital, I feel like so many women are broken. They just never figured out a balance of, they've never gotten their peace back, or, so how do you deal with that with your patients?
There's a couple of fact sheets that sometimes it's easier for people to start with, just reading some easy facts about it. And then I always offer our social workers, who are just great resources, and also, an objective person outside of the area to sort of decide, would you do better from a therapist or something beyond that? Or is it enough just to have the information? Like, some people they just want the facts, and then they want to know how they move on. Yeah. And even our national organization, ACOG, American College of OBGYN, web resources just about miscarriage, or even signs to tell if you think you're having a miscarriage, you don't know. For everybody, it's going to be at a different stage. And for many women, it's not just that pregnancy, that right there, that 8 weeks or 9 weeks. They were already thinking, 9 months from now, and they were thinking 3 years from now, and what that family was going to be like, or the child was going to be like. And so acknowledging that whole picture is a loss. And I think just acknowledge that it's okay to grieve, even if it feels like it's not, something big to other people. It's big to the person. And then in the hospital, for women who are further along, and when women deliver stillborns, we make memory boxes, and do footprints and collect, whatever they really want to put in this box, so that they can have some sort of closure, or they can not look at it at the time. Like, some women don't want to, at the time of the loss, can't really handle that, but we can give them something to look at later if they want.
Are there any other resources to make you feel like you're moving forward? I have someone that recently had a miscarriage, a friend of mine, and she's just she feels like she lost herself. So I'm saying resources like that. Are there any? I know, speaking to a social worker, but.
Well, I mean, I think often people get into like a reactive depression. So making sure that we're recognizing signs of depression. And sometimes that's hard because in the immediate time you expect people to be sad and, have a reaction, but needing to really check in with people. Usually I'll check in with women around 2 weeks after an event and have them come back to my office. And that's a good time where I feel like I get a sense of it. 2 weeks, if things are still really hard and heavy and they're not like, oh, I'm sad, but I see things going forward, I'm hopeful, I'm moving on, that's when I sort of start talking to them about, like, sometimes people go into a depression from an event. The same way that if you lost a family member or had another major life event could happen. And then I think the other like complicating thing is that your hormones just totally change too. Sometimes women get into a thing where their identity gets linked with a pregnancy or with the idea of having a child. That's really common. And we just have to recognize if it becomes more than just an initial reaction and sadness, if it slips into a depression, and try to give people tools of how to get out. But I do think talking about it is important. And I love that you have this series because I think it's important for women to see other women who've gone through things and know that it's a topic that's okay to talk about, and that there are people who will listen.
What do you advise for the one who gets pregnant again? Okay, so now you're pregnant again. You had some losses or you had a loss. Now you're just so focused on, oh my goodness, I'm anxious, I'm nervous, I'm not sure. Like, you're just so focused on your losses instead of what's happening now.
It's hard because it's hard to guarantee somebody, obviously, certain outcomes, but good news is that most women, especially with early losses, have successful next pregnancies. I think just acknowledging that, it's okay to grieve a loss, but it's also okay to move on and you just got to recognize that anxiety. Because if I have somebody who's been through that, like, I'm going to be able to treat them better by saying, listen, you don't medically need an ultrasound at 9 weeks, but we're going to get you an ultrasound, or we're going to do it in the office so that you can feel relaxed, because often it's around the time where an event's happened previously that women get really nervous. I think at least having access into a provider, even if it's just to ask, like, I had spotting. I tell a lot of my patients, you have this history, you have bleeding. It doesn't matter to me. Come in, I'll do a check, make sure that everything's progressing fine. Yeah. And I think that, finding somebody that understands, at least to allow you to do that, I think is helpful. And then usually as things go on, people can feel more hopeful about the next time.
Yeah, I think that's really important. Focusing on moving forward, and it's a whole different pregnancy. It's not your last. That's a big thing, to give this pregnancy a chance instead of, relaying it to the others.
And every pregnancy is different. So, that's hopefully a good thing for most women.
Yes. I brought you on here to create awareness and for people to be more knowledgeable on pregnancy and losses with pregnancy. You talked about high risk earlier, and I want to get into that because it's very important to me. Inducing before 40 weeks, high risk. I've heard other women talk about, like, oh, your baby's not going to be fully developed. Why would your doctor be taking out the baby that early? There's a stigma on inducing. Is there medical reason to induce, or what's the benefit?
So I think that's a great question, because in the past, it used to be that women would get induced after 37 weeks, which was considered 37 weeks we consider full term. And so whether it was like a scheduled C-section or an induction, a lot of women were getting induced, and then it was causing more risk of C-section, or the baby was developed, like they're ready, physically developed, but sometimes their respiratory transition takes a little bit longer at 37 weeks versus 39 weeks. So in the last 5 years, there's been a huge push to not do what we call elective inductions, like meaning there's no medical reason to induce the pregnancy before 39 weeks. Okay. 39 weeks seems to be this like magic time where the baby isn't going to do any better staying in longer. And inducing at 39 weeks in a very large study that was published a couple years ago called the ARRIVE trial showed that actually women induced at 39 weeks versus waiting to 40 or 41 or 42 had lower rates of C-section and better outcomes for the moms and the babies. And they were like very small differences, but overall did better. So that led people to sort of look at this 39 weeks as a more magical number than they had before. But the reasons we induce people before 39 weeks are because we worry that either the baby is going to grow better or do better outside of the uterus than inside, or mom has a medical reason. For example, mom gets high blood pressure or preeclampsia or something that could be dangerous to both of them. Then the need is to, deliver the baby. And we're very lucky here that we have really good pediatric support. And so, even after 28 weeks, like babies are going to do well in our neonatal ICU and our NICU, but certainly after 37 weeks, they're going to do very well, even if they need a little extra support early on. And then 39 weeks, we really don't see so many like unnecessary admissions to the neonatal ICU. But I think women worry a lot too about being like forcing their body into something that's not natural, like the labor didn't start on its own, so it's not meant to be, and letting things happen. And definitely there's something to be said for that. I mean, women who go into labor on their own spend less time in labor than if they're induced and we're having to get your body to do it, but certainly can be benefits to getting delivered earlier.
My cousin, she delivered at 36 weeks and her baby was 4 pounds 6 ounces, and he did not go in the NICU at all, just went home to be with her. Yeah. And then I have another friend that just delivered at 37 weeks, like maybe 2 weeks ago. And all her other babies were delivered before 37 weeks. So I kind of wanted you to talk about that.
Yeah. Inductions after 39 weeks are considered safe. They don't lead to higher risk for the mom. And then between 37 and 39 weeks, we will often do inductions when there's another underlying condition. We induce a lot of people who have high blood pressure, preeclampsia, who have a history of a poor obstetric outcome, because at this point we've achieved a healthy term baby. Then it's worth taking the small percent risk that baby might need some additional support in an ICU, which is probably 3 to 4%, where support meaning they just need someone to watch them clear out all the fluid in their lungs, for 24 hours. 96% of those babies are going to come out just fine. In people who don't have any history, obviously we do try to have them wait until 39 weeks or until they go into labor on their own.
How many babies have you delivered?
So I deliver about 180 patients per year, and I've been here for 15 years. So that's somewhere between like 2,500 and 3,000 deliveries. Some years more than others. And then mixed into that, of course, are women who have stillborns, women who have intrauterine fetal demise. And then I also practice gynecology, which is where I see a lot of my early pregnancy loss patients, because they don't come in to see me in my obstetric practice. And that, I tell people all the time, listen, I see you, you have your loss, I'm going to see you again for a happy, normal pregnancy. And I know it's hard to see that always at the time. And I don't want to undermine the fact that they need to grieve a loss at that time. But I want women to know, like, we see this and we see the other end of it too. Yeah, so I do have kids. I have 4 kids. I have 2 boys and then I had twins. And, pregnancy and having kids and raising them is hard, but going there and getting pregnant and going through that whole process wasn't completely straightforward for me either. And I did myself have a couple of pregnancy losses in the process. So I think that sometimes helps me be able to give perspective to other women who have decided that they want to pursue pregnancy. It's not always easy and it's not always fun. And I think the way it's portrayed on TV, you think like, oh, anyone can get pregnant at any time. And at the end of the day, it's a miracle that it all comes together and, you know, comes out the right way at the end of it. Sometimes it just takes waiting and going through loss and heartache to get to the other side.
Well, thank you for being so transparent and honest with us. Everyone's story is like so imperative, and it can be so influential and inspiring to someone else. So I'm happy that you're able to do that on the channel with me. So I did some research on you, and basically you're a 5-star provider.
Ooh, thank you.
And so we need more people like you, you know, in this world. What would you tell other providers, or what do you say, what are your values other providers or even nurses can take away from you to have the same qualities as you? That
I don't know. Thank you. I just honestly think sometimes people just need to listen more. I mean, I like to talk, so I need to listen more too. But normally when things click with me with patients, it's because I'm just listening to something they're saying that nobody else has listened to or acknowledged as legitimate. And I think that's just, at the end of the day, remembering that everyone's experience is their own and is personal and needs to be treated with respect regardless. Like, your experience is going to be different than mine. And maybe if I had something and it wasn't a big deal, it's going to be different to you because you're in a different place. And to be able to just say, I hear you, and, you know, acknowledge that discomfort or that hurt or that concern. So just listen better.
Yeah.
We don't have all the answers, but sometimes it's just saying, I hear you, and I will try to help you with the things that are bothering you.
Thank you so much, Dr. Juliana Schantz-Dunn, for being on my channel and for talking with us and just giving us some knowledge and awareness on pregnancy and miscarriages, stillborns, and infant loss. This is so, what is the word? Informative.
Thank you.
For myself and even for others that are, you know, trying to conceive or have already done that and, you know, have lost their babies or, you know, just moving forward. I think this is very informative. So I really appreciate your time. And I thank you so much again.
You're very welcome. And I think that's, you know, educating ourselves as women and as, you know, women going through the healthcare system is always important because it's going to enable you to have a better voice.
Is there anything else that you want to like tell my followers or my chosen family, any type of inspiring words or like a charge to them for moving forward or anything?
I don't know. I just always think like after the storm, out comes the sun, right? And sometimes we just have to get through the rain, but the sun will come out.
That's beautiful. Thank you. Well, thank you so much for tuning into Chosen. Again, my name is Erin and Daneele, and my special guest was Dr. Schantz-Dunn. Remember, you are rooted in confidence, so be fearless, be bold, be great, be brave, and don't stop being you.